All right, everybody. Welcome to the Professional Aspects uh, lecture for your Intro to Surgical Technology class. This class is going to be filled with a lot of information for you. But first and foremost, let's get it started on introducing you to surgical technology. And then the second part of this lecture will be about um, uh, I'm sorry, about the legal aspects of surgical technology. These are important. It is included on your CST exam, and it is something that you have to know in this profession, in this position, because you are there for patient safety. So let's get into this. First, I'm going to start off with your intro to surgical technology. So, CSTs are health professionals who are integral part of the team provided surgical care to patients. They facilitate the safe and effective conduct of surgical procedures, ensuring that the operating environment is safe, equipment functions properly, and operative procedures are conducted under conditions that maximize safety. Very important. Safety is important. All right, so you have your roles of your surgical team. You're going to have 4 team members typically. You're going to have your surgeon, your CST, your anesthesia, and your circulator. And you guys are all responsible collectively as a team for 3 phases. Those 3 phases are referred to as perioperative. And then if you split them into subcategories, you're going to have your preoperative, your intraoperative, and your postoperative. All of your roles and responsibilities do vary. Some are very different. Some are together as a team throughout these phases. You have sterile and non-sterile team members. Principles of asepsis are very important. That is something you are going to learn about throughout your program, and sterile techniques. So for a surgical technologist, their preoperative responsibilities include you're going to gather your case cart, you're going to review patient information, you arrange your OR equipment, perform your surgical scrub, do your morning first case of the day cleaning, don sterile gown and gloves, create and maintain the sterile field, prepare, label, and handle meds at the sterile field, initial counts, gown and glove the surgeon, and your draping. Intraoperatively, as a surgical technologist, your responsibilities are going to be to maintain a sterile field, surgical timeout, anticipate surgeons' needs, pass instruments, prepare irrigation and other meds, additional counts, and the application of sterile dressings. Your post-operative responsibilities as a surgical technologist include you're going to maintain the sterile field until the patient has left the room. This is extremely important in ENT and cardiac cases. Separate instruments and supplies, identify reusable items, place sharps in secured sharps container, place contaminated items in biohazard bags, transport instruments and reusable items to decontam, and you're going to do your room turnover. So then in the room, you can also have a second scrub, which will be a CST. This is not a guaranteed thing, and there's a lot of time that this is not, someone may not be available. But in the case that you do have a second scrub CST, their responsibilities include to sponge the surgical wound, suction blood and body fluids, assist your surgeon with wound closure, including cutting sutures, apply electrocautery to clamps on bleeders, hold retractors or instruments, and maneuver the endoscopic camera. So you'll have a surgical first assist. In some cases, you may have a PA, physician's assistant, in the OR with you. They are almost fulfilling the same role as your surgical first assist. A lot of times they're going to assist with your patient positioning. They're going to assist with your draping. Surgical timeout, provide exposure and visualization. assist in identifying anatomical structures, assist in achieving temporary or permanent hemostasis, closure of body planes, apply dressings, assist in transferring the patient from the OR. And then you have your surgeon. Your surgeon is going to determine the necessity of the surgical interventions, discuss risks and benefits with the patient. They're going to obtain your surgical consent, perform your surgical timeout. Typically, your circulator is going to do most of this. Some surgeons do participate in the surgical timeout. They're always in the room when it happens, but some of them don't do a lot of the speaking. They have the circulator do most of it. They're going to perform the surgical procedure, and they're going to provide post-operative care. So your anesthesia care provider is always going to be non-sterile. Preoperatively, they're going to assess the patient. They're going to determine their anesthesia route, discuss risks and benefits of the plan, obtain informed consent for anesthesia, offer alternative anesthesia, determine patient position with the surgeon, manage all phases of anesthesia, monitor vital signs, and provide support such as administering fluid, blood and blood products, and airway management. A lot of times, they're going to do some injections for your gallbladder procedures for your dye. Your circulator, always going to be non-sterile. These are their responsibilities. Start to finish, they have quite a few. They're going to assist the CST with your OR prep. They're going to help you out in the beginning of your setting up. They're going to help you open up, get you ready. If you scrub in and you realize you need something as you're setting up, a lot of times they'll get that for you to help you out. You do want to try to go through your supplies first, though, so you're not sending the circulator running. Ensure documentation is available. Pre-operative interview. Transport the patient from pre-op to the OR. They're going to then assist with patient positioning, perform your skin prep. They're going to do the catheter, connect your cords and your tubes once you are scrubbed in and you need to pass off to them. They do perform your surgical timeout. They help with during the surgery. They will help the CST if they need something, since the CST is scrubbed in and is sterile. Obviously, they need the circulator to be opening their supplies. They do charting and they do specimen care. Once you collect the specimen and hand it off, they are responsible for fully labeling that specimen. Teamwork within the OR. Obviously, we want to have politeness and respect, positive team interactions, willingness to reach a compromise if there is some sort of disagreement. You want to have a common goal. More often than not, that's going to be patient safety. And then a discussion about any issues you may have. And both need to be willing to make some changes. So we're all responsible for our own actions. Your scope of practice is going to be defined as identifies the knowledge and skills required for the professional surgical technologist to provide effective and reliable care. And this is based on your education, your experience, and your national credentialing as a surgical tech. That does include being a certified CST. The surgical technologist performs tasks in the operating room. You are under the authority of the surgeon. They are considered the captain of the ship within the OR. We can only do what we are legally trained to do. That is by the book. You should not be swaying from that. If someone asks us to do something we are not trained to do not do it. Ask yourself, was the task taught in our surgical technology program? Am I willing to take full responsibility for what I'm about to do? This is a patient safety concern. So you want to stick to your scope of practice. Let me just check. I wanted to see if if there was anyone in the waiting room because I was getting a notification. Um, I do not see anything on here. Okay, so let's keep moving along on here for this. So your surgical technology students are credentialed by certification. MBS TSA is the National Board of Surgical Technology and Surgical Assisting. They administer what? On the next slide, I'll have the answers for you. CAHEP, Commission on Accreditation of Allied Health Education Programs, sets the standards for blank programs. ARC STSA, Accreditation Review Council on Education in Surgical Technology and Surgical Assisting, directly oversees what part of the program? Guys, remember this is an overview. This is a review. A lot of this information is stuff that you should have seen throughout your program. I'm just giving you guys a good review for it for the CST exam. I will have questions throughout all of my lectures for you guys to participate, answer in your mind, but they will be there for sure. So your MBS TSA administers the certification exam. CAHEP sets the standards for surgical technology programs. ARC STSA is going to directly oversee the educational part of the program. They also do the accreditation reviews. Your legal terms you need to remember: accountability, to be held responsible for your own actions; affidavit, sworn written statement of facts; allegation, a claim that someone has done something illegal or wrong, usually made without any proof; bona fide, sincere without intention to deceive; guardian, court-appointed guardian to care for someone who cannot take care of themselves, minor children and incapacitated adults. Legal terms: laterogenic injury is going to be an injury caused by a healthcare worker; liability, obligation to do something or not do something. Your standard of care is the conduct that is expected of a healthcare professional in given circumstances. Health professionals must recognize responsibility to patients first and other health professionals, provide competent medical care, respect human dignity and human rights. This is a big one. Malpractice versus negligence. Malpractice is going to be when a medical professional does something or doesn't do something that causes injury to the patient. Negligence, carelessness, but no intention to do harm. Failure to use reasonable care. Another professional would not do the same thing in the circumstance. So let's look at some examples, some questions. So this is a malpractice versus negligence examples quiz. So poor positioning that injured a patient. What would you consider that? Performing surgery on the wrong side or site. Abandonment, leaving the patient at any given time without proper protection for the patient. This in the OR includes leaving the room when a patient is still undergoing surgery. And if you get upset because you're not getting a break and you leave, that is considered patient abandonment. Something left in the body during surgery. Patient burns from prep solution or the cautery. So let's see which is which. So your poor positioning is going to be negligence. Performing surgery on the wrong side is also negligence. Abandonment is malpractice. Something left in the body is going to be negligence. And patient burns from prep solution or the cautery is going to be negligence. So let's go back and look at the definitions. Malpractice, when a medical professional does something or doesn't do something that causes injury. Negligence, carelessness, but no intention to do harm. So make sure you know the difference between the two. Your tort is going to be a wrongful act that results in injury to another person's property or reputation, and the injured party is entitled to compensation. Torts can be intentional or unintentional. The term tort is kind of like a case file or like reading a case. That's what a tort is. So, all right. Intentional torts. Assault, threat of bodily harm with the intent to actually cause bodily harm. Battery, intentional, unlawful touching of someone without their consent. You actually want to cause harm. Defamation is oral or written statement about someone that is untrue and can damage their reputation. Invasion of privacy, discussing private information about the patient without their consent. Again, these are important terms that you should know. Assault versus battery. A surgical technologist is in the OR with a patient under local anesthesia and says, "If you don't stay still, I'll hold you down myself." Is this going to be considered assault or battery? A surgical technologist applies a grounding pad or begins prepping a surgical site on the wrong limb without confirming consent or correct site. Is this considered assault or battery? Performing any procedure without consent, assault or battery. Threatening or implying harm without touching, assault or battery. All right, let's take a look at the next slide and see. All right, so I gave you a minute to review. So if a surgical technologist is in the OR with a patient under local anesthesia and says, "If you don't stay still, I'll hold you down," this is considered assault. If a surgical technologist applies a grounding pad or begins prepping a surgical site on the wrong limb without confirming consent or correct site, this is going to be considered battery. Performing any procedure without consent is considered battery. This is a good thing to remember. Threatening or implying harm without touching, that is going to be considered assault. Unintentional torts. So here's some examples. Patient misidentification. Here's some questions for you. Should a patient's wristband be removed before they leave the hospital? Yes or no? Transport should check the ID bracelet before or after bringing the patient into the OR. The preoperative nurse in the holding area should check the name on the blank with the name on the blank. What two things do they check for the patient's name? The patient is requested to state their name and it should blank the ID bracelet. Should the circulator and anesthesiologist confirm the patient's identity? Who is the last person to check the patient's identification? All right. Should a patient's wristband be removed before they leave the hospital? Never. The answer is never. Transport should check the ID bracelet before or after bringing the patient into the OR. Before. The preoperative nurse in the holding area should check the name on the bracelet with the name on the chart. They should match. The patient is requested to state their name and it should match the ID bracelet. Should the circulator and anesthesiologist confirm the patient's identity? Yes. Who is the last person to check the patient's identification? The surgeon. All right, let's go into some consents. General consent, this is going to be separate from surgery. So signed upon admission to the hospital, signed to perform day-to-day treatment, And then, as you see, additional consent is required for surgery. Informed consent. Who is responsible for obtaining the informed consent? Informed consent is going to be an oral and written consent that is signed before a patient has a surgical procedure. The informed consent is obtained by the surgeon. The information regarding consent includes patient's name, surgeon's name, procedure, signature of the patient and witness, and the date of the signatures. The surgeon is responsible for obtaining the consent. They should clearly explain procedure, risks involved, benefits, alternatives, and complications. Important note about language barrier. This is a fact you should remember. It has appeared on some CST exams, from my understanding. The patient must receive this information in terms that they understand. If the patient does not fully understand what the physician informed them about the procedure because they have a language barrier and something went wrong, then this could constitute assault and battery. Don't forget that. If there is a language barrier, it is considered assault and battery. Information prior to the patient signing the consent includes exactly who will perform the procedure and who will assist. The consent must be signed before the patient has received any preoperative medication. The circulating nurse should ensure that this process has taken place before the patient is admitted. Patients should sign the consent themselves unless they are, so these are the exceptions, minors, unconscious, mentally incompetent, illiterate, or life-threatening situation. Who can sign in these instances? So with a minor, you're looking for a parent or guardian. If they're unconscious, a responsible relative or guardian, obviously next of kin. Mentally incompetent, you're going to go to the legal guardian. Illiterate, they may sign with an X. Life-threatening, next closest relative is authorized to sign. If the patient is incompetent due to drugs or alcohol, the closest relative may sign if it is an emergency. If not an emergency, they have to wait for a detox. Witnessing consent can be a nurse or other facility employee. The witness must verify patient signature, the signature was made voluntarily, and that the patient had a sound mental state. Consent in an emergency. How many surgeons must be called in to witness that the patient is in a life-threatening situation? How many nurses must witness a phone consent? There's 2 questions for you, and then I'll go ahead and give you the answers. So 2 nurses must monitor the call and sign a legal form for phone consent. 2 surgeons may be called in to witness the patient is in a life-threatening situation and needs surgery. They sign a legal form. The 2 surgeons must not be part of the patient's care team. So this is going to be 2 new, fresh eyes that come in and they see what's going on and decide about the surgery. No, every patient has the right to refuse a surgical procedure at any time. The surgeon and nurse document the patient's refusal for surgery and all sign. This will relieve the hospital and healthcare team from any liability. Advance directive, a document that allows the patient to give instructions about their medical care in the event they become incapacitated and cannot speak for themselves. Additional information can include information on organ donation. So with an advance directive, an example is a C-section. If something happens to the mother while the C-section is happening or while she's giving birth, she has given an advance directive. These can be filled out at the hospital of what is to happen. An example of it, again, is going to be the C-section. Due to fetal distress, she becomes unconscious before surgery. Her chart will include the advance directive that she filled out, stating that she refuses blood transfusions, commonly seen with certain religious beliefs. During the C-section, the patient begins to hemorrhage and would normally require a blood transfusion. Because of the advanced directive, the surgical team does not administer blood products, even though it is medically indicated. Important notes: refusal of treatment like blood equals legally binding advanced directive. Ignoring it equals battery and legal violation. Key concept: patient autonomy overrides provider preference. So this is different from a living will. So your living will is going to specify types of medical intervention that the patient does not want. Examples include feeding tubes and ventilator. Power of attorney, you will see this a lot with older people. So document that authorizes a designated person to make decisions for a patient if they are incapacitated and cannot make decisions for themselves. A power of attorney does not only have to be a family member, it can be anyone that they chose to appoint for that position, I suppose. It must be legally designated. They must have paperwork. If no POA exists, you have to follow the facility and the legal hierarchy. POA example: a patient is scheduled for surgery but becomes unconscious after a complication in pre-op. In the chart, it states that the patient has assigned their spouse as their durable power of attorney for healthcare. Because the patient cannot make decisions, the spouse is contacted and gives legal consent for the additional procedure. A DNR. This is do not resuscitate. A lot of people who work in healthcare or that you have seen, I'm sure you've heard of it in clinicals. This is going to be no to CPR. So no matter what, it is a no to CPR if the patient has decided on a DNR. And again, that is a legally binding paper and typically is told to everyone. Incident report is going to be a written statement regarding an accident involving a patient or employee. The details should be written as statements of facts without your opinion. This should be reported to the nurse manager. Example include needle sticks, falls, loss of instruments. This is a little bit different than, say, a sentinel event, which is something that occurs in surgery actually to the patient. Intraoperative legal responsibilities. So everyone in this class should be participating in a timeout during their clinicals, but we're still going to go over it. It should be a universal thing, but I can say it is not always the information provided is not always a universal thing. But yes, timeouts are universal. So anyone can initiate the timeout. However, it is usually the circulator. Everyone in the room must stop and pay close attention to the timeout. Everyone in the room should be in agreement with the info and verbally agree to it. Can anyone tell me what the timeout includes? So your timeout is supposed to include confirming the patient's name, procedure, and where the incision will be made. So your surgical site. So that's left or right for extremities. And then left or right, say for breasts or whichever side of the body. Anesthesia has addressed any patient concerns, allergies, if antibiotics have been given, estimated blood loss, all films, supplies, and equipment are ready, must be confirmed. Are there any specific concerns? And then does everyone agree? And I know a lot of the surgeons I've worked with will ask the surgical tech if they have everything they need. Foreign bodies left in the patient. Counts must be completed between the surgical technologist and the circulator. Verify and or verbally and or visually. These counts are to occur before the case begins when closing a hollow cavity, peritoneum, and the skin. Patient burns in the OR include, so these are patient burns can become a tort. It can become an issue, depending because a patient can get an infection from a burn. Uh, and if it is something that was negligence, um, they they can become a big deal, especially if it causes an infection, like in an older patient or an open wound. So hot instruments, you're going to cool off instruments from the autoclave with cool, sterile water. That's going to be before you hand it to the surgeon to be used. You don't want to hand them something that's really hot. Placing the return electrode improperly. A lot of times your Bovie pads are going to be placed by the circulator. ESU should be placed in its holster when not in use. Do not clamp the ESU cords with a metal instrument. Obviously, a metal instrument is not insulated, so it's going to conduct electricity. You do not want that shock, that electrical shock. Electrical equipment should be tested prior to use. Improper use of lasers and neglect of laser safety. Pooled prep solutions under the patient, that can be a really big deal. It doesn't seem like it, but those prep solutions are very strong. And if they just sit on the skin for that long and are wet and still, they don't dry when they're pulled, they can actually cause skin burns and irritation. Hot irrigation solutions. A lot of times you use warm irrigation, especially in the abdomen. You want to make sure those are not hot. And then again, with your fluid warmer, you want to make sure that that's not too hot. Anesthesia, flammable gases, light cords that are placed on the patient's drapes. Falls or improper patient positioning. So your side rails should always be up when transferring the patient, and all extremities should be kept inside the bed rails. The stretcher and OR table should be locked when transferring the patient. Ensure proper padding. Understand positioning techniques and work together. And how many inches above the knee should the safety strap be placed? Usually it's just a couple. I think it's 2 inches above the knee. Proper amount of people when moving the patient. So a mobile patient is going to be 2. An immobile patient, which is typically after surgery, is always going to be 4. You're going to have your anesthesia. You're going to have someone at the feet, and then you're going to have one on each of the sides doing the kind of lifting, rolling, pulling, pushing thing for the patient. Anesthesia controls the head and the time of transfer. It is always up to the anesthesia, no matter what. They are in charge of that airway. Incorrect administration of drugs. The surgical technologist and the circulator should verify verbally and visually the correct drug expiration date and amount. The surgical technologist must label the med cup, pitcher, syringe as soon as the drug is received and the syringe is filled. When passing the syringe to the surgeon, the surgical technologist should state the medication and the percentage. This is something that you will see people not do. But by the book, this is absolutely what you should be doing, and this may be asked on the test. So you need to remember that when passing the syringe, you need to say the medication and the percentage. Agar primo, the patient first. Primum non nocere. Above all, do no harm. Res ispa, I never say these right, but that is the thing that speaks for itself. And respondent superior, let the master answer. These are important decrees, especially the agar primo for surgical technologists. They are something to remember. So things to remember: be responsible for any breaks in sterile technique you make. SSI are caused by breaks in technique. They can be tracked back to someone who does not follow sterile technique. Let me fix that spelling. The surgical technologist is under the direct authority of the surgeon. However, we should not do anything that is out of our scope of practice. It is illegal. So what that's saying is you are under the surgeon, but it does not give them the right to have you do something that is not within your scope of practice. And, there has been recent stories of I don't know if you've seen it, but a surgeon that took out the spleen and he was supposed to take out the liver, and the whole story hasn't come out, but people in the room were speaking up supposedly. But this type of stuff is a problem. If you feel as though something is happening that shouldn't, you are to speak up as a surgical technologist, even if it is the surgeon. So let's go through some review questions here at the end, because for you guys, this is your review course. So I want to go through some questions together. If you're listening afterwards, maybe grab a piece of paper so you can write down and answer these questions. And I'll go through them a little with a little bit of time for you. So let me just wait a second and see if for you guys to maybe grab a piece of paper if you're watching this afterwards or even live. All right, let's get into it. So, a patient was burned on the lip with a hot mouth gag. Which of the following actions would have prevented this incident? A, the circulator cooled the item in the sterilizer. B, the scrub tech warned the surgeon that the item was hot. C, the scrub tech cooled the item in a basin with sterile water. D, the surgeon has checked the item before using it. I'm going to give it a second for you to answer. All right. So the answer is C. The scrub tech cooled the item in a basin with sterile water. I did go over this in the lecture. It is the responsibility of the scrub tech to cool an instrument in cool sterile water before handing it to the surgeon. Burns are one of the most frequent causes of lawsuits. All right. The Latin phrase agar primo refers to A, patient first, B, do no harm, C, breathe, or D, it speaks for itself. A, patient first. Accreditation for surgical technology programs is done by A, ARC STSA, B, CAHEP, C, AORM, or D, JACO. B, CAHEP accredits programs upon recommendation of the ARC STSA. Failing to observe or act in a situation that the individual should have known about and acted on is called A, negligence, B, abandonment, C, guilt, or D, defamation. A, negligence. Negligence is legally defined as the omission to do something that a reasonable person, guided by those ordinary considerations that regulate human affairs, would do. A patient signs a permission form for surgery, but because of a language barrier, he or she does not fully understand what he or she has signed. This could constitute a liability case. Would you consider this assault and battery, lack of accountability, improper documentation, or invasion of privacy? This is going to be considered assault and battery. Lack of consent is an aspect of assault and battery. Consent must be given voluntarily with full understanding of the implication. Give me 1 second. I'm having a little bit of an issue with the PowerPoint. So okay. So if a patient falls because he or she was left unattended, the OR team member could be cited in a lawsuit for A, misconduct, B, assault, C, doctrine of respondent superior, or D, abandonment. Now remember, what they're saying is that someone left the surgery while it was happening, okay? And you left them unattended. So which would that be considered? D, abandonment. So anytime you leave someone unattended, that is abandonment. The doctrine of respondent superior refers to A, the legal terms and assault and battery, for assault and battery, I'm sorry. B, invasion of privacy. C, employer liability for employees' negligent conduct. Or D, professional misconduct. The answer is C, employer liability for employees' negligent conduct. An employer may be liable for an employee's negligent conduct under respondent superior, master servant employment relationship. This implies that the master will answer for the acts of the servant. A document in which a person gives instructions about his or her medical care in the event that the individual cannot speak is A, hospital policy, B, administrative law, C, ethical deposition, or D, advance directive. D, advance directive. The legal document signed by the patient before surgery is it an operative report, a safe medical act, an ethical policy, or an informed consent? Informed consent. When a negligence suit is filed against a hospital, who is named? The surgeon, the RN, the surgical technologist, or every person that played a part in that surgery? Every person that played a part in that surgery. When a negligence suit is filed, everyone in contact with that patient will be named in the suit. The Health Insurance Portability and Accountability Act, HIPAA, gives patients the right to have elective surgery, or are privacy standards to protect the patient's medical records, or gives patients the right to sue their doctor, or allows patients to see any physician they choose. Which one is what does HIPAA constitute? The answer is HIPAA. HIPAA is privacy standards to protect the patient's medical records. In the event that a child needs emergency surgery and the parents cannot be located to sign the permission form, which one of these options is the procedure? No permission is necessary. Permission is signed by a court of law. Permission is signed by the physician. A written consultation by two physicians other than the surgeon will suffice. A written consultation by two physicians other than the surgeon will suffice. All right. Next question. The patient is scheduled for an appendectomy. After completing this procedure, the surgeon decides to remove a mole from the shoulder while the patient is still under anesthesia. No permission was obtained for this. What should happen next? So, which one of these do you feel would happen next? You would report it to the anesthesiologist, report it to the chief of surgery, report it to the supervisor or proper administrative authority. Let the surgeon proceed because it is his or her responsibility to obtain the consent. Obviously, when you're in the situation, a lot of times, for some people, it's hard to speak up, and they would just assume it's okay because the surgeon is doing it. But just because they're a surgeon does not mean that everything that they're doing is okay. So let's go ahead and take a look at the answer. You're going to report it to the supervisor or proper administrative authority. Next question. The surgical consent form can be witnessed by which of the following except? So this is one of those questions where they use the word except. I spoke about this in my exam review video for you, these questions with the word except. So the surgical consent form can be witnessed by each of the following except. So your choices are the surgeon, a nurse, an authorized hospital employee, or the patient's spouse. You are looking for the 3 trues and 1 false, and the 1 false is going to be your answer. The patient's spouse. Everyone else in that list are allowed to witness the surgical consent. And those 3 were the surgeon, a nurse, an authorized hospital employee. The patient is pre-medicated and brought to the operating room for a cystoscopy and an open reduction of the wrist. Upon arrival in the OR, it is observed that the patient has only signed for the cysto. The correct procedure would be, so which one of these choices? Cancel surgery until a valid permission can be obtained. Have the patient sign for the additional procedure in the OR. Ask the patient verbally for consent and have witnesses attest to it. Or let the surgeon make the decisions as to whether surgery could be done. So let's go back and look at the question. It does say in there that the patient is pre-medicated. Nope, that's the answer. That the patient is pre-medicated and that they were brought to the operating room. So they're already under the influence of drugs. And your 2 procedures that you believe they were brought to the operating room for is going to be your cysto and your open reduction. So when you realize that they only signed for a cystoscopy, the correct procedure would be they are going to cancel surgery until a valid permission can be obtained. This is completely up to the patient. So if they're already pre-medicated, then you will not go through with the surgery because everything doesn't match. So what is implied consent? Is the preferred option for consent. It is allowed by law in emergencies when no other authorized person may be contacted, is never legally valid, is the permission for surgical action. Which one of these is considered implied consent? So implied consent is allowed by law in emergencies when no other authorized person may be contacted. Which document allows a patient to give instructions regarding their medical care in the event that they become incapacitated and cannot speak for themselves? A living will, power of attorney, advance directive, or DNR. So again, this is that they become incapacitated and cannot speak for themselves. And it is regarding medical care. Okay. This is going to be your advance directive. What is a protocol for consent forms for illiterate persons who cannot write? Which one of these? So the closest relative can sign for them, explain the situation and omit signature. 2 physicians unrelated to the case must be in agreement that surgery is required, or they can sign with an X. So you want to look back at the question and see that it is an illiterate person, not a person with a language barrier. So that's two different situations. Okay. So I'll give you a second, let you look through the answers again. So an illiterate person who cannot write, they can sign with an X. Again, not the same as the language barrier. This is totally different. Consents are required for anesthesia, blood and blood products, experimental treatments. I got to fix that. Or all of the above. Which one? So this one is going to be all of the above: anesthesia, blood and blood products, and experimental treatments. So this concludes our discussion on professional aspects, including your consents, and then your procedures within the OR. And then also you do have your video on your exam study strategy, which is part of this week's lessons. You do need to make sure that you are watching these videos. uh, I can see if the videos are being watched or not watched. But this is very important information for your CST exam. It is part of what is going to be asked on that exam. And at the beginning of this video, I did tell you how much of it is on the exam. So, all right. Well, thank you very much and enjoy your evening.